So here are two cases I'd like to present. One to highlight a couple of very important principles about the acute GI bleeding management in case one, and elective management of antithrombotic drugs. So here's case one. This is an 87-year-old gentleman who has atrial fibrillation with a CHADS-2 VAS score of 4, which means his annual risk of thromboembolism is about 15%. He was taken off Coumadin after multiple episodes of iron deficiency, anemia, and melena. He has a past history of myocardial infarction, has had a CABG bypass procedure. He has ischemic cardiomyopathy with an ejection fraction that is low at 20%. He has moderate aortic stenosis but no mechanical valve, and chronic kidney disease stage 4. This is the average patient we see at Mayo Clinic. Is that what you see where you live? He currently, because of his bleeding episodes, is only on aspirin 81 milligrams per day. But since 2012 has had 70 inpatient encounters for GI bleeding. He has had multiple endoscopies that have shown Gillifoss lesions, bleeding, small intestinal arteriovenous malformations. He's had gastric ulcers from his aspirin. We know he has diverticulosis. He's had reflux esophagitis, and we have found colonic polyps. So I met him in the emergency room when I first moved to Mayo Clinic in March of 2013. He was the first patient in the door, so I knew I had moved to the right place. He presented with melena and acute on chronic anemia with a hemoglobin decrease from 8.2 to 5.7. But because he was so used to bleeding, he was hemodynamically stable. We did bidirectional endoscopy, or the doctor who had seen him during the day did bidirectional endoscopy, and then I came on at lunchtime that day, and there was no bleeding. So the first thing I did was I put down a capsule, all right? If you have normal bidirectional endoscopy, you put down a capsule. And indeed, what do we see? We saw blood. Within 30% of his transit time, within the first 30%, we saw blood. So we knew that he had a small intestinal bleed. And this is what the point I want to make about cardiac patients. They often have small intestinal bleed. So you have to become much better at how you image the small intestine. And I'm going to leave you some practical comments here. When the patient has an overt GI bleed, melenic stools, hematochezia, bright red blood from the bottom, you know that something's going on now. These are not the patients who have no symptoms except for iron deficiency anemia. But when you see overt symptoms, you must act aggressively. Because if you do, you can find the source of the bleeding and make a big difference for this man who needs his antithrombotic drugs. And in fact, small bowel endoscopy performed within 24 hours compared to non-urgent small bowel endoscopy vastly increases your yield of finding the diagnosis, 93% versus 64.3%. And we know that there are two ways of imaging the small bowel: capsule endoscopy and double balloon or push enteroscopy. And what's important about capsule endoscopy is the benefit of seeing the lesion, or the chance of catching the actively bleeding lesion, deteriorates over time. In bright yellow, amarillo, I've heard is the term in Spanish, amarillo, overt, right? This was my guy. We dropped the capsule the same day as bidirectional because we wanted to catch the bleed, and we caught the bleed. As you see, as you go down to 10 to 14 days, you go from 90% to 70% chance of catching the bleed, right? So don't delay. The imaging of the small bowel after normal bidirectional endoscopy should be a late second thought. It should be your immediate second thought. Then we saw the bleed. The next day, because he was prepped, he went to double balloon. And why do we do that? Again, in the yellow. When he has overt symptoms, that's our greatest chance of catching and diagnosing and treating the bleed. And in fact, you still have a little bit of wiggle room. Within the first month, you will be successful 84% of the time. But often when people say double balloon or deep enteroscopy doesn't work, they're waiting too long. to get it done. You've got to act while the iron is hot. Here's the data that shows that when you have a suspected small intestinal source, you should triage or determine what end of the small intestine the bleed is happening with the capsule first. Then if it's within the first 30% of the transit time, you know it's anterograde, or from the top. If it's anything later, you go retrograde, or through the bottom, correct? And the combination of the two is better than either modality alone. So you should always have a plan for how you're going to aggressively treat and find that small intestinal bleed. Because in cardiac patients, they bleed a lot from the small intestine. All right, here's what we did. Next day anterograde, we see the clot. We inject, we remove, never leave a clot. Inject it with epinephrine in a cardiac patient. Never leave it, because you'll be there that night once they restart the drug. So best defense is a good offense. So you inject with epinephrine, you take care of that clot, you get rid of it, you see what's below it, and you deal with it. In this case, we used argon plasma coagulation. And then because this gentleman has already had the pleasure of our business 70 times in the last 1 year, we tattooed it so we could find the source again. Here's case 2. So the lesson from number 1, be aggressive about looking for a small intestinal source in your cardiac patients and get on top of it and do it quickly. All right? Case number 2, here's our elective case. 51-year-old man with a family history of colorectal cancer, no prior colonoscopy. He had an ST elevated MI with percutaneous coronary intervention and the placement of a drug-eluting stent 13 months ago following his acute coronary syndrome. And he had bad luck. He had a stent occlusion, okay, requiring reimplantation of the stent. So that, right there in that second bullet, is a very high-risk cardiac patient, all right? That's the clue, the stent, okay? He was on dual antiplatelet therapy with aspirin and Plavix, had some asthma, no other serious comorbidities or labs, and your plan was to do elective screening colonoscopy. So how should you manage his antiplatelet therapy? You all know the answer to that after the first 3 speakers. Remember, the thromboembolic risk of the patient is the probability of event depends on 3 factors. The indication for the antiplatelet therapy, in his case, he has ACS, ischemic heart disease, and a stent. The consequence of thromboembolic event, well, consequence for him, because he's already had a stent occlusion, which is a super high risk cardiac patient, is death, right? So we need to deal with that, and any additional risk factors. The only thing that would have made that case worse is if he had been a diabetic, but he wasn't. We've shown you this. He's beyond the first 90 days, so you can start thinking about electively treating him. He's also beyond the first 12 months of his stent placement and his stent occlusion. So it's appropriate for you to start thinking about doing his screening colonoscopy because he has a strong family history of polyps. But I want to talk to you about stent thrombosis, all right? For all you GI fellows who might be in the room, read the cardiac history, okay? If there's been stent thrombosis, 1 in 5 patients who've had 1 stent thrombosis will have another. That's what puts him at a super high risk. And the outcome of stent thrombosis, in most cases, 30% of them die. He was part of the lucky 70%, all right? And it's more common with patients who've had drug-eluting stents versus the bare metal. And that over 3 years, the rate is about 3%. But what's interesting is you can see from this graph, you would think that the incidence would go down over time. But in these patients who've had 1 stent occlusion, that risk actually creeps up a little each and every year. His family history of polyps is not going to go away. So this is a patient you're going to need to get to know well and to know how to do safely. So in this case, you could, because he's 13 months out from his his drug-eluting stent placement, right? He's on dual antiplatelet therapy with Plavix and aspirin. In this patient, you could stop the Plavix for 7 days before your colonoscopy, keep him on aspirin, 81 milligrams, explain to him the risks associated with thromboembolism because he's at super high risk, right? Document it in the chart. And then you have to have another conversation. What are the chances that I'm going to find a polyp in you? What am I going to do with that polyp? And you're going to take it out. The guy's got a strong family history. You don't leave a polyp behind. What are the chances of him bleeding? So let's talk about that. We know, this is just one of multiple studies. If you're interested in this topic, I really would direct you to the literature of Linda Fagans from Texas. She's done a lot of work in this area. But here's an important study that shows you that the use of clopidogrel, Plavix, or aspirin, stopping it or not stopping it, doesn't impact, really, the post-polypectomy bleed rate. And you think, well, why is that? Because the effect on the platelet lasts 7 to 10 days, and we're only getting you to stop the Plavix 7 days before. So in 11% of patients who are on dual antiplatelet therapy, even if you stop the Plavix 7 days before, 11% of them are still going to bleed. I tell patients that right up front so that they're not afraid. Right? And in this case, in this patient, I said, listen, I think it is safer for you to take a chance, 11% chance of bleeding after I take off your polyps than the 30% chance of your stent occluding and clotting off and death by stopping both drugs. Right? And when you put it to them that way, they're like, oh yeah, doctor, I agree with you. The other most important thing you need to tell the patient is, don't get excited about it. 11% of patients on aspirin are going to bleed. We know what to do with that, a post-polypectomy bleed. These are the symptoms. If you see any of these symptoms, within the first month, remember, the eschar will often come off in 2 weeks, and then there's a delayed bleed after week 2 to 1 month. If these symptoms occur, no big deal. You call us, we take care of it. Half the battle with cardiac patients is giving them the impression you know what you're doing, all right? After this afternoon session, you do know what you're doing, all right? I have never been sued, knock on wood, even though I see a lot of these patients. But that's because I communicate, and I tell them very frankly the pros and the cons, the risks and the benefits, and then I document. And that's called what we call shared decision making, because every patient needs to know, and they can't make informed choices unless you talk to them. These are not the patients you want to see in open access without having been seen in clinic first, right? These are not your routine colonoscopy patients. These are the ones you should be seeing before you do endoscopy and having these conversations. We've talked about this too many times, but the reason we've talked about this too many times is because it's so incredibly important. You never stop the cardiac aspirin. Stopping cardiac aspirin in a patient like this has a high chance of death. You've heard it in English twice and in Spanish once. So you're not going to do that anymore. So here are my most important tips from my cases, all right? With overt GI bleeding and suspected small intestinal source, have a plan for the next step when you have negative bidirectional endoscopy. The imaging of the small intestine should not be a late second thought as you're eating your wonderful tacos at dinner saying, oh, that patient, Mr. Lopez, maybe I should arrange a capsule. No, you do it that day, okay? You find the blood. Because where there's smoke, there's fire, all right? You just need to find it. Now you have about 2 weeks to get the enteroscopy done, but you want to do the capsule while the overt symptoms are happening, okay? Use the capsule first, because that will help you triage the direction by which you go in, anterograde from the top or retrograde from the bottom for the double balloon. Remember, it is always safe to perform endoscopy on aspirin monotherapy, so you're never going to stop it, right? If you have a patient at 325, by all means, drop it to 81 milligrams, but you do not need to stop it. When it comes to thienopyridines, we've been talking mostly about Plavix, but remember that the elective procedures and the temporary interruption changes depending on the drug. It's not 5 days for warfarin, 5 days for all anticoagulations, and 7 days for all antiplatelets. Know those tables, right? If you just take 2 of those tables from the ASG guideline and put them in your endoscopy suite, you won't forget. Don't forget the 3 golden periods of death for a cardiac patient. First 90 days of ACS, first 30 days following a stent insertion of any type, and you want to be deferring elective exams. My polypectomy patient would not be being done during that time. You can do any low-risk procedure while maintaining patient on drugs, okay? But the most important thing is restarting the drugs as soon as you have immediate hemostasis. Delaying the start of resumption of drugs leads to bad outcomes. Thank you.